Hi, I'm Jutta Bergler-Klein and I will teach you everything you need to know about aortic stenosis. So let's get started. So let's look at the natural history of patients with aortic stenosis. Importantly, even patients with severe aortic stenosis can remain asymptomatic for long periods of time, even over years. However, this graph shows clearly that once symptoms occur, the mortality rate will increase rapidly without valve replacement. These patients must therefore be referred for surgery at once. Aortic stenosis is actually the third most common heart disease, and the prevalence increases with age, with a prevalence of 2 to 6% in elderly people. 30% of old people have aortic valve sclerosis, which is an important precursor of aortic stenosis. So, what actually happens in aortic stenosis? Aortic valve stenosis leads to increased afterload of the left ventricle. Therefore, the left ventricle must cope with increased pressure overload. This will lead to increased filling pressure and concentric left ventricular hypertrophy, with consequently diastolic dysfunction due to increased stiffness of the myocardium. When the adaptation or coping mechanisms of the left ventricle are exhausted, in long-standing severe aortic stenosis, the left ventricle reacts with dilatation and reduced left ventricular function. The consequences are low output and further increased filling pressure. And finally, we will see the full-blown picture of heart failure. So let's look now at the causes of aortic stenosis. In younger patients, the most common cause is congenital malformation, such as bicuspid or even unicuspid aortic valve. However, in elderly patients, most frequently we will see calcified degenerative aortic valve stenosis. Another cause can be rheumatic origin, although this has become rare in Western countries and usually also involves the mitral valve. In patients younger than 70 years old, the most common cause is congenital malformation, especially bicuspid aortic valve. In older patients, older than 70 years old, the most common cause is degenerative and calcification of the valve. Other causes include post-inflammatory after endocarditis, for example, or rheumatic disease, or a combination of these causes. So the most important thing is to remember that in younger patients, younger than 50 years of age, severe aortic stenosis is almost always congenitally caused, usually bicuspid aortic valve. Here we see two examples of aortic stenosis forms. On the left side, a classical bicuspid aortic valve syndrome with the doming of the aortic cusps and also the thickened edges, and typically also the dilated aorta ascendens, as frequently found in congenital aortic disease. On the other hand is the calcified aortic stenosis with the typically highly thickened and calcified aortic cusps with only poor residual opening seen with the cusps and also the left ventricular hypertrophy. In rheumatic aortic stenosis, usually we find only mild to moderate aortic stenosis, and typically we can see these thickened edges of the aortic cusps, usually also combined with aortic regurgitation, and very frequently the mitral valve is also involved. Look at the doming here of the anterior mitral leaflet pointing towards mitral stenosis, which is also frequently found in rheumatic aortic stenosis. This is a very nice example of a congenital malformation of the aortic valve, showing a typical bicuspid aortic valve, almost resembling a mouth. Very rarely we can also find unicuspid or quadricuspid valves. It is very important to remember that congenital abnormalities of the aortic valve, especially the bicuspid valve, present a syndrome that frequently involves the aortic root, with development of ectasia and aortic aneurysm. Here we can also see a typical example of such a patient. These patients have to be followed regularly for aortic measurements, because aortic aneurysm can lead to very dramatic consequences with even dissection in these frequently young patients. So now let's have a look at how Tommy evaluates the morphology of an aortic valve in a real patient.
The best way to look at the aortic valve is from the peristernal approach. And we'll start with the long axis. And immediately you can note that the aortic valve is calcified. What we can do here is we can try to appreciate the severity of calcification. In this case, it is not severely calcified. I would say moderately calcified. And we can also see that the calcification is not only on the valve, but also right here in the myocardium. The next thing we can look at is the motion of the aortic valve. It's certainly not a normal opening and closing excursion of the valve, but it's a doming of the valve, which is maybe not so easy to see in this view. And the third thing we can see is that the ascending aorta is dilated. So altogether, this information gives you a good feel for, I would say, the morphology of the valve. It must be a bicuspid valve, and the calcification is moderate. Severity of the aortic stenosis is very difficult to quantify here, but if we look at the opening excursion, it's certainly not normal, so there must be some degree of aortic stenosis. The next view we can take a look at is the apical view. So in the apical view, again, we see the calcification of the valve. Here's the 5-chamber view. The calcification here usually looks more than it actually is from the peristernal approach. And again, we can see that the calcification reaches right here into the myocardium. And this is also visible here in the apical long axis view. So in summary, bicuspid aortic valve, moderately calcified, probably some degree of calcification. How much calcification is, we'll have to look at the continuous wave Doppler spectrum.
Now let's look at how we actually assess the AV morphology in echocardiography. In the short axis view, we can nicely evaluate the aortic valve, visualize the individual cusps, and assess if it's tricuspid or bicuspid or perhaps with a raphe. And we can observe if the valve is still opening adequately or, for example, severely calcified. The M mode gives important clues whether the valve is bicuspid. In these cases, we do not find the regular box caused by the cusps of the aortic valve, but instead eccentric AV closure. Importantly, in a severely stenotic valve, the box separation is much smaller and also irregular. Here we can see examples for the degree of calcification in degenerative aortic stenosis. The severity or degree of aortic stenosis is often associated also with the degree of calcification of the valve. Heavily calcified valves point to severe aortic stenosis with a probable rapid progression towards symptom development in asymptomatic patients and the near future indication for valve replacement.
So, are you ready for the next demo?
Which features can we see in patients with aortic stenosis? The first thing that we'll appreciate immediately in the 2D echo is that the patient has left ventricular hypertrophy. We can see that in the short axis view, concentric left ventricular hypertrophy. We can measure the thickness of the septum. In his case, it's somewhere around 15 millimeters, so moderately thickened. The next thing we can appreciate is that the patient has a dilated ascending aorta. We can measure this, and we notice that it is far above 40 millimeters. It's 46 millimeters, so dilated. And we can also see that the patient has an enlarged left atrium. In his case, only mildly enlarged. We'll measure this using planimetry of the left atrium in one dimension in the apical four-chamber view. And we get an area of 24.4 square centimeters.
Ventricular hypertrophy reflects the increased afterload in aortic stenosis and therefore increases with the severity of aortic stenosis. Additional hypertension is frequently present, especially in elderly patients. However, hypertension increases further the global load of the ventricle, also called now the valvulo-arterial impedance. And therefore, hypertension plays an important role in how much the left ventricle can tolerate before decompensation. Look here at this severe LV hypertrophy causing a very small cavity of the left ventricle. This is frequently seen in concentric left ventricular hypertrophy. Coronary disease is also very frequent in calcified aortic stenosis and may even have a common pathway. Ischemia and myocardial infarction or scars lead to remodeling of the left ventricle. The additional impairment caused by ischemia leads to further reduced left ventricular function. Look here at this akinetic area here in the apex and also of the anterior septum. Another frequent feature in aortic stenosis is left atrial enlargement. This is caused by elevated filling pressures and diastolic dysfunction caused by the increased afterload. This may also have prognostic implication and may often lead to atrial flutter or arrhythmias. Importantly, diastolic dysfunction is caused by reduced compliance in hypertrophy and increased stiffness of the myocardium, which can also be caused by subendocardial ischemia. Filling pressures are increased in the ventricle, indirectly reflecting the severity of aortic stenosis and increasing further the impairment of the ventricular function. This finally correlates and translates into symptoms. Here we can see a nice example of restrictive diastolic dysfunction. It is also very important to recognize that mitral annulus calcification is frequently associated with aortic stenosis. The aortic calcification may actually spread to the anterior mitral leaflet and interfere with the movement of the mitral valve, leading to mitral stenosis. Color Doppler can be very useful to detect further abnormalities around the aortic valve. Very frequently we see aliasing caused by the stenotic jet. The turbulences can also point to subvalvular stenosis or to a secondary LVOT obstruction, also which can be caused by septal bulge, or even in supravalvular aortic stenosis, which can also well be seen in color Doppler. Look here at the heavily calcified aortic valve, also accompanied by aortic regurgitation and the severe hypertrophy of the left ventricle. There even seems to be some pericardial effusion here.
In this chapter, we talked about the causes of aortic stenosis and the hemodynamics. In the next chapter, you will learn how to quantify aortic stenosis.